कौन है? गौरव? ये कौन? Hi, good morning, everybody. Dr. Bhalla, can you hear me? Uh, Good morning, Dr. Bhalla. Oh, hi. Hi, morning. Good morning, everybody. And so this, yes, I'm going to start with the femto, which I'll show the femto procedure, and then I think Dr. Harbanslal will do the safe surgery, and after that, I'll take the patient for in the OT. So, good morning, everybody, and I'm going to start, and I'm going to show you the femto procedure. Uh, the first question is why a femto? A lot of practices, a lot of surgeons come down to ask me why a femto, and I feel that it is the need of the hour. It's not that because of the technology; it's just because the demand of the patients. Why did we get a femto? Is because we were losing a lot of patients who were from our practice just going away because they needed a laser cataract surgery. So that's why a femto, and that's my simple answer to that. Now, we're working on the Catalyst machine by Johnson Johnson, one of the best femto laser machines, femto cataract machines around, and it does, and I think it has more installations than any other machine all over the world. It is very simple to use, so we've just fed in the data here. If you can see the screen here, we've fed in the patient's data and the K1, the K2, and the anterior sleep axis. Actually, now these Yeah. So, right. Sorry, there was some technical glitch here. So, here is the K1 and K2 which we feed in, but in the newer softwares, this gets transported from the biometry directly. So you don't have to feed in any data here, and you don't even have to choose any eye because everything comes in here. I have chosen to do a capsulotomy here. So I'll be doing the capsulotomy, the nucleus fragmentation, and the incisions. I'm not doing the LRIs or the toric marking because I do not have too much of an astigmatism to deal with. So I'll be dealing with this gentleman, Mr. Singh. So this is the data which has come onto the machine. Go on to the next one, and it does tell me the capsulotomy, what size I have to make. So basically, I've changed from that template to a 5.2. The incision depth, that means how much I will be ablating for the capsulotomy is 450 microns with a pulse energy of 4.2. So I will be finishing my capsulotomy in less than a second. So next, I have just taken octants, and I prefer not to fragment the pieces anymore. I don't soften them just because there are small pieces which get lost below the iris or in the angle, and you sometimes tend to lose them and leave them behind. So I now prefer not to do any softening. Just if it is a very, very hard cataract, then I go ahead and do it. This is a medium grade cataract, and I'll just be doing octants. And I'll be making this incision. And as per the data which we saw there, my steeper axis was at 135, and I'll make my incision at 135. I have fed in a data of 2.3 millimeters as the part of the soft docking to the eye. See it on the screen. Okay. Just putting the liquid in the cup here, and I will move the patient under the machine. Lock. हाँ, मैं फिर से कर रहा हूँ, लाइट के अंदर देखिएगा, मेकिंग श्योर दैट द लिड्स आर अपार्ट। थोड़ा सा नीचे देखिएगा, थोड़ा सा नीचे देखिए, और नीचे थोड़ा सा। So here we go again. So there we go, and I will have to suppress my main incision just because it's a 12 millimeter and I don't see the limbus all around. So I come here and then I press the next one, capture, and once this is in the center, I press lock and fluid confirmed. Now the OCT starts working. So the OCT will show me the anterior capsule, the posterior capsule, as well as the cornea, the AC depth. So that's the anterior corneal parameter in the red. The green one is the posterior corneal, the teal color and the purple color are the anterior and posterior. Pupil is there, and I can actually move it around slightly, but I think I'll just suppress the limbus. So on zero, I approve the data which is showing me on the OCT. The capsulotomy is all right, as well as my fragmentation, and incision I will suppress because this will come a lot interiorly. So I approve it, and then it is, as I said, that it will be less than 1 second. It's a 0.7 second of laser time. Right. So the capsulotomy is complete, and we're going on with the fragmentation. I'm making the octants as I did feed it into the machine, and that takes about 28 seconds. So we've got another 17 seconds to go. The patient is comfortable. There is no problem. I can see the fragmentation happening in front of me, and I can actually see the capsulotomy with the pneumobubbles which are coming up. I can actually see the capsulotomy, which is a free-floating capsulotomy now. So the fragmentation is aligned to 135 as I had done, but I had not made my incision, so that does not matter. I'll be making my incision on the steeper axis on the table. So now I release the vacuum, I get the patient down again, and the patient comes out. आप ठीक हैं जी? कोई दिक्कत तो नहीं हुआ? चलिए, आप उठ सकते हैं, अब अंदर हम आपका लेंस डालेंगे. So this was the catalyst, a very simple procedure, and I think it's as I said that it's the way forward for all cataract surgeons, and at one stage or the other we'll have to move on to this technology. Thank you. Yes, I think Dr. Harbans Lal will be. Nothing to worry. Shift to Are we audible?
Hello, Dr. Balla. Can you hear me? Yeah, good morning.
फीड आ रहा है फीड जा रहा है OT1 को
Okay.
हाँ
Yeah, put this surgery on. I already done capsulorhexis and hydro procedure. So we are going to use the Signature Pro machine.
यहाँ रखो.
Hello, can you see this surgery? Yeah. Okay. So I'm going to use the Kelman tip, and that is my preferred tip. And I always use the incision size of 2.2 millimeter. I'm going to operate on a Signature Pro phaco machine. It is excellent machine, and it gives very good chamber stability even at a high vacuum. That means when I operate a hard cataract, I usually use the setting of 600, 650. And so what I'm doing is I'm removing the epinucleus plate from the anterior surface of the nucleus so that the anterior surface of the nucleus is bare. And my preferred technique is stop and chop. But this nucleus is getting shifted, already lifted, so I can just go and chop it. FACO 2 पे कर दो. So my settings are now vacuum is 500, flow rate is 40, and the how much is the power? And continuous irrigation mode on, please. So whenever you are inside the eye, you should always be in a continuous irrigation mode on, so you don't have to worry about the maintenance of the chamber. You can see the chamber is absolutely stable, while flow rate settings are quite high. No, I continue with the same parameters. Only thing I've removed the chopper so that there is no leakage from the side port, and I kept the tip horizontal instead of keeping it vertical. By any chance, if the posterior capsule comes forward, it won't hit the tip. Only if the epinucleus is. So now I'm just putting in a viscoelastic before we're drying so that the chamber depth is always maintained. So that will prevent unnecessary vitreodonosis and will decrease the ischemia and inflammation. So I do not allow the chamber to collapse at any stage of the surgery. So whenever my infusion comes out, I always put on a viscoelastic inside the eye. So now I use the bimanual technique without having the bimanual two incisions. So I use the main port as one of this, and the only problem is the sub-incisional of the side port. You can remove from the same, but then you'll have to turn it, the tip down, which may cause distortion of the wound. So now you can see I keep the cannula slightly tilted, so there is no leakage in spite of the cannula being very thin. So I don't have to make a second side port. So still I got the advantage of the bimanual, but it has to be a continuous mode. So now I'll put on a viscoelastic again before I withdraw my infusion. Continuous बंद कर दो. Now I'm going to use the IHANS lens system. This is the and how this. So this is one of the, I think, best innovation we have, in the sense that we always wanted the patients to have some intermediate vision so that the ladies can work in the kitchen, can do the makeup, men can shave, and they can walk comfortably. So if you have got a 0.5, 0.75 addition, then actually all the um, even a patient is emmetropic, around 1 meter, 2 meter distance, he can see reasonably very well. Use for pushing. So this is my actually preferred lens. And even if you want to have a perfect distance vision, some of the patients may be demanding, I can use for reading. So this lens, because it has got a very good landing, that means even if the patient is plus 0.25, he will have a perfect vision for 6.6. That means if the patient wants primarily a distant dominant vision, use it as a synergy. That means when it is a plus 0.17, plus 0.25, there is no problem. If it is a minus 0.25, he'll get a better near vision. And if patient wants to use more like a mobile and the laptop, then use it like a symphony. That means the first eye is around minus 0.25 and second eye is minus 0.75. So it will give it excellent infusion cannula. I'm giving counter pressure. You can see I have positioned the lens in an axis where the rexis was large, so that the optic is still covered, though the rexis is slightly larger on the superior temporal side. So you put the long axis of the IOL on the long axis of the rexis. Hydration ले देना. Bottle height कम कर दो. Yeah, yeah. Mhm. No, this is only the patient's. Yeah, lower the bottle height, please, to 50 centimeter. Yeah. So the first eye when you do, then you talk to the patient ki whether he wants better vision for near and distance. Switch off the continuous. Switch off the continuous. So the if patient wants better vision for near, accordingly we'll plan ki what he has got in the other eye. So that is second eye is always depends upon what patient wants. So if suppose patient has got a 6 vision for distance and feels that he'll be happy having a little bit of a near vision, then you plan minus 0.75 something in eye hands, which will give him excellent computer vision. Antibiotic. And if patient has got say antibiotic, point, huh? This much, just 0.1, no? Hmm? So that will always depend upon so so swab sticks, two swab sticks to press the wound. So I always press the wound and check one more. So if you see the wound is leaking by any chance, then instead of keep on hydrating, keep it pressed for 30-40 seconds, it will seal. Because now the tunnel will get compressed and count up to 100 or so, and it will get sealed. So many people keep on hydrating there and should leave no wound leaking. And so this lens that way is very good because it has got no side effect and can still give very good even the macular drusen, early ERM, where you want to really avoid the multifocal lens, but still patient wants to have a reasonably good working vision. I think this lens serves that purpose very well.
Thank you, Harvan sir, for a lovely presentation. Can we now shift to OT2? OT2?
Yeah, sure.
Can we have the feed from OT2? Dr. Saurabh is ready with his patient.
बहुत अच्छा होगा ऑपरेशन, आपने बहुत अच्छा कोऑपरेट किया, बहुत अच्छा होगा. हाँ, थैंक यू था. हाँ, thank you. There was that build up. Yeah. खोल दिया.
Hi. Hello, am I audible?
Yes, sir.
Okay, so I have this patient. I demonstrated the femto for. So you can actually see in a retro illumination that there are pneumo bubbles which have slightly dissected the lens as well. So I will not be able of doing a good hydro dissection. I just use a very little fluid. Now the patient's astigmatism is at 136. The steeper axis is there, though it does not require any LRIs or the arcuate incisions. आप लाइट में देखिएगा. So I'll just make one side port here, and that did go and touch, but that's already the capsulotomy, and I will make my main wound at 136 here. I could not do the incision on the table because I had to use the 12 millimeter LOI. So that's my main wound. मेरे को उससे पहले हाँ देवेंद्र जी थोड़ा सा जलन होगा मैं दवाई डाल रहा हूँ थोड़ी सी so I will go and do a little bit of hydro here very gently press it down and I have a free porting capsule so I don't need to do anything about it. Hmm. I will go on to the phaco and as you can see the initial steps were just like a cakewalk. There was nothing which I had to do and I will now go in with my phaco. Because of the octants which I've made, I need not chop it properly, but I will definitely need to separate them. So I'm using the Signature Pro. Going in slightly tightly through the 2 point. Right. So here I start the aspiration, and as I aspirate, I get the capsulotomy, the capsule, the free floating capsule out. I go in with my second instrument. I rotate it slightly. Along the cleavage planes, I'm just separating them. Here, one. While chopping, I have to make sure that I'm rotating them so that they're in the right opposite. But here I can go ahead and do 2, 3 chops together. So just going into the octants which I had made. So these are the laser. All these pieces are getting separate. Got it. So now I am holding each piece, making sure they're separate. Sorry. So I do a hydrodissection, but as I showed before the surgery, there was a good pneumodissection which was done. So I had to do very little. So I was using phenocane, and I did my hydrodissection with the phenocane itself. I did not do a good hydrodissection just because there was a pneumodissection. And I did not, because it was a free floating, I didn't even have to remove the capsule, right? I could see actually it was a free floating capsule. So I went in, I just aspirated it out with my phaco probe. So now it's easy cakewalk. I need not chop it, but just I'm using very little power because it's a grade 2 nucleus. And because of the fallibility of the machine, most of the pieces are coming and I don't have to run after the pieces, right? So they're coming in the center and I'm emulsifying them in the center of the bag here. So there's one small fragment. I'm back to the center of the bag, the epinucleus. So just aspirating the epinucleus out. And I just go around a little bit here so that the fluid which is coming in through the phaco probe, the sleeve, just separates the. I see another small. Uh, वैक्यूम बढ़ा देंगे वैक्यूम कितना है वैक्यूम 600 कर देंगे प्लीज Putting in viscoelastic, and I'm now ready for the lens injection. So inflating the bag here, putting some visco on the cornea. हाँ जी, आप ठीक है ना जी, कोई दिक्कत तो नहीं हुआ? बढ़िया जी. अब मैं आपके I've loaded the lens has been loaded onto the injector. It's the Eyhance lens. So the beauty about this lens is that it can give you a bit of near vision. That means that you can shave, you can actually see the computer a little bit, and it comes at a cost of a monofocal. So it's a premium monofocal lens, and quite a bit of our practice have moved on to the Eyhance lenses. थोड़ा सा झटका धक्का लगेगा जी जैसे लेंस जाएगा. हाँ जी. So I put the leading haptic into the bag, and I just push the trailing haptic also there, and I will wait for it to unfold. So basically what the lens has is a higher spherical abrasion in the center, and once there is a higher spherical abrasion, sorry, the sphericity in the center, so from the periphery to the center, the sphericity increased, and that gives the little extra depth of focus. Though this is not a EDOF, but it can behave like one, and I've been trying to toy around with it, trying to make some patients slightly myopic in one eye. And I do see that the patients are doing pretty well after getting them myopic. Visco mein? Yes. So I get into the visco mode of the machine, and I have increased my vacuum to 650. That's the maximum that can go up. And I am removing the viscoelastic from the cornea, and now from the angle behind the, and then I go behind the IOL. So I went behind the iris, and then I will go behind the IOL and do with my port up. I'm just removing the visco from behind. I am also going to rotate it slightly so that I'm keeping it temporal and pushing it slightly. Sorry, I'm keeping it temporal and nasal orientation of the haptics, and I'm slightly pushing it towards the nasal side. So keeping it on the nasal side, I'm not very sure, but there were a few studies which said that the negative dysphotopsia is a lot less if we are decentering the lens a little bit. I am through with the procedure. I just need to hydrate this wound, which is लाइट दिख रहा है ना जी. दिखना बंद हो जाएगा तो बताएंगे प्लीज. So that's my hydration bit, and the last bit what I have to check is that give a slight nudge to the IOL back into the bag. Yeah, and move it slightly towards the nasal side. That done. Light दिखना बंद हो जाएगा तो बताएंगे. Just the sealing of the incision. That's my routine. And the AC is well formed. It's not too. Thank you, just pushing in a little moxifloxacin.
Thank you, Saurav sir. That was a brilliant, brilliant case. Can we please have the transmission from OT1 now?
Thank you. Thank you, everybody.
Dr. Himlata is ready with her patient. Can we have the stream in OT1?
Thank you. Thank you, Dr. Namrata. ठीक है जी.
Do we have the stream?
अभी आपको उठा रहे हैं, पट्टी बैंडेज करेंगे ना.
हेलो.
हाँ, पट्टी करके उठा रहे हैं आपको. आप फिर घर जाके पट्टी उतार देंगे. ठीक है जी. बढ़िया हो गया जी ऑपरेशन.
Stream from OT1, please. Yes.
Thank you. Thank you, sir. Thank you.
Now in OT1, Dr. Himlata, she is a senior consultant at Center for Sight, associate with us for the past many years, and she is one of the topmost surgeons, not only in Center for Sight, probably all over India and my with that what we feel. And now she is ready with her patient. Over to you, ma'am.
Very good morning to all of you. Am I audible? Am I audible?
Yes.
Yeah. A very good, a very good morning to all of you. So I'll be doing this case. Is a 74-year-old male. So already the femto has been done, and post femto there was a little constriction of the pupil. So I've already made a side port and injected phenocaine so that the pupil now is well dilated. So I'll be starting with the surgery by removing the already cut capsule. So as you can see, it's already a free floating capsule. The femto has been done with catalyst platform. I'll be doing minimal hydrodissection. That already pneumodissection happens in femto cases, so we need not do much of the hydrodissection. So this is Signature Pro that I'm using. So you can see that already the femto has been done, so it's so easy to chop it further. So now I'll move to the quadrant. Please switch to the quadrant parameters. So already softening has been done by femto, so very less energy is used. You can see that with the Signature Pro, as the other surgeons have demonstrated, the chamber stability is really good. There's no surge and no fluctuation of the anterior chamber. So this is the last piece that is left. I'll be a little. Since this chamber stability is very good, even at the last piece, one need not reduce the parameters. So I can do safely proceed with the same parameters that I used at the beginning. Cortex. So here I remove the cortical matter. ये तो कॉर्निया से बबल हटा दूं, कॉर्निया वेट कर. Lens load. So here the cortex removal is complete. I always use the coaxial irrigation and aspiration cannula. And now here I'll be showing you the implantation of the new Technis iHands toric, which is on toric 2 platform. Can somebody show the toric chart? So this patient has 1.62 astigmatism at 2 degrees. So here this injected. So complete viscoelastic removal is a must. So this iHands toric 2 platform is like really good. They have changed the haptics a little bit, so there is a frosting of the margin of the haptics along with the square edge transition, and now the rotational stability of this IOL is like really good. So the patient with eye hand toric, they are almost 6/6 the very next day, and I haven't seen any rotational instability with this lens till date. Sir, we have in this like particular patient, but a little bit of like 3-degree rotation is still expected. So might the JNJ is coming up with a new platform where that thing also will be improved. So this is the end of the surgery. You can see a very well aligned IOL, and that's it. ठीक हो गया है बाबूजी. Yeah, sir. With femto, yeah, with femto rexes, we just make sure that it's like 360-degree covered with the rexes. And that I make sure. And the visco removal, if it is complete even behind the IOL, then the alignment of the lenses can be checked that ways. इतने पर अभी छठा बता से पूछना पड़ेगा मुझे. आपके पास लगाइए वैसे तो मुझे आपको काम होता है. हटा दो.
We can hear you.
Sorry, Delikan. Shut up.
Hello? Yeah, okay. Good. Hi, Dr. Alkesh. Hi, how are you? I can hear everybody. I hope you can hear me as well. Light बढ़ा सकते हैं? Illumination. मेरा ना एक रेक्सेस मार्कर होगा उसमें. ले लिया? ठीक है. हाँ, perfect. Good, yeah, thanks. Hi, Dr. Alkesh. So I'll be operating on the Signature Pro here, and I'm planning to use a toric lens. I'm planning to use an eye-hands toric. This patient has significant astigmatism. पहले rexus marker. Yes, what else? So I use a rexus marker for my rexus when I'm not using the catalyst, and this leaves a good mark. Let's see. Side put. And it gives you a perfect rexus in the absence of a femto. 23. So mostly because these patients are all under topical. Yeah, because they're all under topical and you can see the reflex on the cornea from the vertex. So you have to center it on that. When the patient is looking into the light, it becomes easy for the patient to look into the light and then you can center it correctly. I'm sorry. Maple. Yeah, so I think it has been a very invaluable visco. So it gives you a very good mark and this mark is usually there.
it's visible. You may end up making a smaller excess sometimes. So this allows you to make a excess which is always of the right size. अच्छा. It, so chamber stability is usually very good. This patient is myopic, so there's a deep chamber. So I am going to do a direct chop. That's what my usual technique is. And usually when you have a very deep chamber, it can be a little challenging. So you have to be careful that if you don't, if you use a very high bottle height, your lens will be bimanual IA systems are made to the same gauge, 22 gauge. Here I've used a 23 gauge side port because 22 was not available immediately. So I might have tight ports for my bimanuals. I may have to enlarge it. But frankly, when your instruments are all calibrated to the side ports, like the bimanual and your chopper and everything, it makes things much better. So now we are going to go to the quadrant. So the chamber stability remains extremely good, and you can get away even with the very hard cataracts with bottle heights of just 40, as I'm showing you right now. And the chamber stability never suffers. And even if you have an inadvertent uh, so under topical anesthesia, there are things like high myopes. If you have a sudden deepening of the chamber, they will suddenly feel pain. So that's why another advantage of doing low IOP phaco here, because high myopes typically will have sudden pain as soon as you distend the chamber and start the infusion. And then depending on the grade of cataract, you can use the power as much as is required. So we've been able to remove the nucleus. ठीक है अब इसको 5 minutes. थोड़ा सा लाइट बढ़ा सकते हैं, अगर माइक्रोस्कोप की लाइट बढ़ा सकते हैं. So the thing is that, yeah, because in this particular OT there was no markerless system. I normally operate on the Calisto or Virion. So here we have marked the 180, and frankly, when I started, the implantation access was not available. I'm going to do it right now once I remove the cortex. Can you check the implantation access? हाँ, कॉर्टेक्स के लिए मशीन हैंग हो गई. हाँ, देखा ना, मैं पहले डाल के देख लूंगी चल रहा है. हाँ तो आई थिंक मैंने साइड पोर्ट थोड़ा बड़ा करना पड़ेगा. इसको दे दो और बड़ा प्लेट दे दो थोड़ा सा. आपका जो 20 वाला था ना, 23 में कुछ ज़्यादा ही फाइन हो गया. मैं वैसे 23 यूज़ करता हूँ, वो देना कुछ, बट हाँ, बट सो ये 20, ये तो 23 है. 20 दे दो. ये वाला था ना आपका, ये दे दो. So I'll have to, because my instruments are made to 22 and the side port was 23, I'm just enlarging my side port a little bit to allow my bimanual to go inside. I would normally use a 22 only, and लाइट में देखते रहे, बस हो गया. बॉटल लाइट कम ही रखना. बॉटल लाइट 40. हाँ, हाँ जी, बस हिलिएगा नहीं. So see, even though I'm using a bottle light which is just 40, the patient is uncomfortable with the pressure. Cornea. So again, because my wounds don't leak much at all, so chamber stability is extremely good, and the machine, of course, is extremely good. The Signature Pro has sent standards in both phacoemulsification and chamber stability and power delivery as well. And even with the hardest of cataracts, one doesn't have to struggle. So I'll be doing a hydroimplantation of the lens. Thankfully, we have a shooter available. So the iHands has replaced the monofocal mostly in my practice because it has almost no contraindications to use, even in patients with maculopathologies and other issues, even with field defects. You can use it, and patients get fairly reasonably good intermediate abilities, which allows them to do their. Rajendra Prasad.
हेलो ठीक है स्टार्ट हो रहा है मेरा आई विल बी रेडी रखना इसमें ज़्यादा टाइम लगेगा आई विल खुलवा के रख लो पहले
हाँ,
खोल के रख लो
Sir, we are shifting over to Dr. Rajendra Prasad. I'll just position the IOL. Thank you so much.
कर दिया कनेक्ट कर दो कनेक्ट हो गया इधर हेलो हेलो हेलो
Thank
Hello.
you. Thank you.
Surgery.
हेलो हेलो हेलो
Admission to OT1.
हेलो 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 डॉक्टर अलकेश डॉक्टर अलकेश हेलो कनेक्ट नहीं हो रहा क्या कनेक्ट कराओ
Do we have feed from OT1? Is Dr. Arti audible?
1-1.
हेलो 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 नहीं कनेक्ट हो रहा हेलो
Okay, sir. Is Rajendra Prasad sir audible?
हेलो डॉक्टर अलकेश तो कनेक्ट कराओ ना उनको क्या कर रहे हैं कनेक्ट नहीं कर रहे क्या
Dial.
उसको बोलो शिफ्ट मत कराओ अभी
Done.
इधर लाओ बोलो उसको उस अमन को बोलो ना अल्केश को फोन करो डॉक्टर राजेंद्र प्रसाद बोल रहे हैं अल्केश को फोन करो
थैंक यू इसको ना सेट को क्लीन करके दोबारा रेडी कराना पड़ेगा क्योंकि दोपहर में मेरे एक और केस राइट इन्फ्लुएंस तो
कल रात को डिनर में ना there was a dish. Okay, okay. कौन हो? Fellowship to Arvind Hospital. Okay. मदुरई पर प्रिया से. अच्छा अच्छा. कौन हो सकता है? Wearing glasses. Tall. ठीक ठीक. Maybe Vashne, but his son actually. हाँ 1981 MBA batch है. Vashne होगा. The one whose son is doing VR surgery in Madurai, I know. He's Vashne. बहुत tall नहीं है थोड़े. ठीक ठीक है ना हाँ Vashne Vashne. He's practicing in North Delhi side. But his son did MD from AIMS. Inside that. He said हाँ so हाँ same yeah. Uh, posterior subcapsular cataract you can see here, and it's not very grade 1 or grade 2 nucleus. Screen shift kar do bhai. And I have already done the capsular axis for this patient. And going to do the hydro dissection. लाइट देखो आप सीधे लाइट देखो अभी हिलाओ नहीं लाइट देखो लाइट देखते हैं so you need to evacuate visco a bit and then take your needle a little below the axis margin and go towards the equator and inject the fluid. So you can see the cortical cleaving hydrodissection, full dissection has been done, and see the fluid wave, and I'll be doing hydrodelineation also. So this is the delineation. I've completely dissected the nucleus now. Give me the visco. लाइट देखो लाइट देखो a bit of visco dissection. So always better to do a bit of visco dissection because then you can completely separate the nucleus and the cortex so that you have a free nucleus. लाइट देखो थोड़ा so you can see the nucleus is fully rotated now. लाइट देखो सीधे नहीं नहीं अभी वो ट्रेंच रहने दो चॉप नहीं ट्रेंच ही रहने दो वो कहाँ गया साकेत को बुलाओ लाइट देखो I'm just removing the epinucleus. So nucleus is not very hard, but so I'll be just showing the top and chop. It's always better to divide this nucleus. Chop. So this was the first half of the nucleus. Manual only in all my cases. लाइट देखो आप बहुत पीछे देख रहे हो लाइट को देखो So I'm going to use Synergy. I will. This is the one of the best hybrid, you can say multifocal hybrid multi technology. कौन सा दिया? मुझे एक्चुअली में ना मेरा वो उसमें नहीं है, चाहिए था, वेट नहीं किया आपने. So I normally use so we normally aim for the complete emetropia in this for this IOL. I don't take it for the hyperop or a myopic side. I normally aim for the emetropic side because this IOL has a both the technology, as you said. This has a EDOF technology as well as multifocal technology. So it has a uh, diffractive component as well as the EDOF component. So it gives you a much clear distance reading and intermediate vision. Light देखो, सीधे light देखो. You can see the rings of the IOL. It takes its time to unfold. Very minimal. This gives you a much. एक मिनट थोड़ा हाइड्रो है ना. See the cases which light देखो, सीधे light देखो. So I normally seal the main node. The main importance is the scotopic vision. It gives you much clear scotopic vision than any other trifocal IOL. It gives you a much clear vision. The reading vision, intermediate vision is much better. Thank you.
Thank you, RP sir. On the case, we all know how RP sir can do hard cases so well. The soft cataract was also done so well. Thank you, sir.
Sorry. Light देखो सीधे. लाइट देखो. बहुत देर तक रहता है ना अंदर, कॉर्निया हीज हो जाता है.
सर मैम कर लेते हैं कि इसके सारे ऑपरेटिंग सर्जन की एक बार फोटो ले लेते हैं.
हाँ हाँ
उनके साथ ले लेते हैं.
चलो.
तब तो उसका आपकी नहीं. तो मैम कर लेते हैं कि डॉक्टर जीना करते हैं. बढ़िया, थैंक यू सो मच.
चलो होगी. कॉर्निया ना हेजी विस्को रहता है ना बहुत देर तक कॉर्निया बिकेम वेरी हेजी वो हेजी हो रखा था इट वाज गेटिंग सो डिफिकल्ट कि मैं हाँ नहीं नहीं जॉब तो खैर थी नहीं इसमें तो पर ये कॉर्निया क्लैरिटी कम हो गई थी ना दिखा मुझे दिख नहीं रहा था ठीक था फिर भी ठीक था नहीं नहीं वो आपको दूसरी कैप्सूल में तो दिख ही नहीं रहा था मेरे को इट वाज नॉट विजिबल एट ऑल एक हफ्ता तो हमारा उसी में निकल गया तो हम ठीक से प्लान नहीं कर पाए
रक्षाबंधन आ गया वो भी
हम्म